I'm going to talk about the clinical trials that have been conducted in early rheumatoid arthritis, established rheumatoid arthritis, and inflammatory bowel disease. As already pointed out, the BEST study, the fourth arm, initiated therapy with infliximab and methotrexate, and then a number of patients, about a quarter of the patients, were able to stop therapy while maintaining low disease activity and remission. But the question is, are there patients in whom one can stop therapy and maintain a drug-free remission? And there are 4 studies in early rheumatoid arthritis that address this topic. The HIT-HARD study, which induced with adalimumab and methotrexate compared to methotrexate alone, and then either continued methotrexate withdrawing adalimumab or continued methotrexate in the patients who'd initially been treated with methotrexate in DMARD-naive patients with early rheumatoid arthritis. The Optima study looked at induction with adalimumab and methotrexate and then treated patients either with continued adalimumab and methotrexate or methotrexate alone in methotrexate and biologic-naive early rheumatoid arthritis patients. PRISE is a study that was published in the New England Journal of Medicine, which looked at induction with full dose etanercept and methotrexate, then dropping the dose of etanercept, continuing methotrexate, dropping the biologic completely, or dropping both drugs, and then finally in patients who were in remission, withdrawing drug therapy and looking to see whether the remission was lasting. And finally, the Avert trial, which already pointed out, looks at induction with abatacept and methotrexate compared to abatacept alone and methotrexate alone, a sort of a tempo trial design in methotrexate-naive early rheumatoid arthritis patients, followed by withdrawal of drug therapy. So to start off reviewing the HIT-HARD study, the HIT-HARD study looked to see whether early induction therapy with an anti-TNF agent within a window of opportunity might lead to a long-lasting effect that can be maintained after biologic withdrawal. This study enrolled 172 patients with active early rheumatoid arthritis. There was an upper age limit of 75. Disease duration was limited to 1 year or less. Patients had typical entry criteria for a rheumatoid arthritis trial, at least 6 swollen and tender joints, and morning stiffness of at least 30 minutes, and then the typical enrollment criterion of a sedimentation rate of at least 28 millimeters per hour or C-reactive protein of 10 milligrams per liter or more. That acute phase reactant criterion in the study that we did looking at the Corona database excludes nearly 60% of patients in clinical practice with rheumatoid arthritis, so that the acute phase reactant requirement in this study limited the enrollment and makes the study less representative of the entire population. As I mentioned, patients were naive both to biologics and methotrexate and had to be on stable nonsteroidal anti-inflammatory drugs and glucocorticoids. So this schema shows the study design. 172 methotrexate and biologic-naive early rheumatoid arthritis patients were randomized 1-to-1 to either receive adalimumab 40 milligrams subcutaneously every other week and methotrexate 15 milligrams subcutaneously weekly, or placebo plus methotrexate. And then at week 24, patients underwent withdrawal of adalimumab and continuation on methotrexate alone. This entire 48-week study was blinded, and the primary endpoint was the DAS28 at week 48. Radiographic progression was a secondary endpoint, and the baseline characteristics show that patients were well matched. They had high disease activity with a DAS28 ESR of mean of 6.2, 6.3, and HACs in the mid-range, which is typical of all clinical trials. What you see here on the left is that the DAS28 in the placebo-controlled portion of the trial decreased for both treatments, a bit more with adalimumab plus methotrexate, but then in the blinded phase with withdrawal of adalimumab or continuation of methotrexate, patients maintained sustained low disease activity. On the right, you see a probability plot looking at radiographic progression, and what you can see here is that there was more radiographic progression in the patients who were initially treated with methotrexate alone compared to those who were treated during the first 24 weeks with adalimumab plus methotrexate, a not unexpected finding given the data from earlier clinical trials of TNF inhibitors. So the conclusions of the HIT-HARD study are that very early treatment of rheumatoid arthritis may control disease activity regardless of whether or not TNF inhibitor therapy is initiated. Also, there was less progression of structural damage from baseline to week 48 in patients who were treated with a combination of adalimumab plus methotrexate to week 24 compared to those receiving methotrexate alone. Moving on to the Optima study, which really was looking at something different than withdrawal of therapy. This was a study designed to assess the clinical, radiographic, and functional outcomes of the combination of adalimumab with methotrexate compared to methotrexate monotherapy in patients with early rheumatoid arthritis who had or had not initially achieved stable low disease activity, defined as a DAS28 CRP of less than 3.2, both at week 22 and week 26. So this was, in general, trying to look at comparing the TNF inhibitor plus methotrexate with methotrexate monotherapy. But the second hypothesis that was addressed by this study was that therapeutic responses would be maintained after withdrawal of adalimumab in patients who initially responded to the combination of adalimumab plus methotrexate. Study enrolled over 1,000 patients with active seropositive or erosive rheumatoid arthritis of less than 1 year duration. Patients were naive both to methotrexate and biologics and could be treated with up to 2 synthetic prior DMARDs. Patients were randomized 1-to-1 to receive induction with 26 weeks of either placebo plus methotrexate or adalimumab plus methotrexate, and treatment modifications were made during the second 48 weeks of the study based on achievement of stable low disease activity. So this slide depicts the schema. Patients were treated randomized 1-to-1 to receive either adalimumab plus methotrexate or placebo plus methotrexate, and those who achieved low disease activity, a DAS28 of 3.2 or less, were then randomized to receive either continued treatment with adalimumab or placebo plus methotrexate, or receive placebo plus methotrexate, or in the case of non-responders to placebo plus methotrexate, to receive open-label adalimumab plus methotrexate. Primary endpoint was comparing these two groups, the patients who achieved low disease activity on adalimumab plus methotrexate and who continued adalimumab plus methotrexate compared to those who achieved low disease activity on placebo plus methotrexate and who continued that treatment. More patients, 44% of the patients treated with adalimumab plus methotrexate achieved low disease activity compared to only 24% of those treated with methotrexate alone. But for the purpose of the comparison that I'll address, we're looking at this group, comparing those patients who were then randomized after initial treatment with adalimumab plus methotrexate to receive either continuation of therapy or placebo plus methotrexate. And here you can see that low disease activity on the left, the upper panel is DAS28 low disease activity, and the lower panel is SDI low disease activity, an SDI score of less than 11. The right-hand panels are DAS28 remission on the top, DAS28 of less than 2.6, and on the bottom an SDI of less than 3.3. And if I can figure out how to use the pointer, here's the pointer. So you can see here that patients who withdrew adalimumab or who continued adalimumab, there were more patients patients in low disease activity than patients on methotrexate monotherapy. So methotrexate monotherapy is, I'm sorry, I misspoke. More patients on continuation of adalimumab or methotrexate monotherapy maintain low disease activity compared to methotrexate withdrawal. Again, I misspoke. Patients on adalimumab continuation did better than patients who are on methotrexate monotherapy or who withdrew adalimumab and continued on methotrexate alone. And you see the same for remission and SDI. Patients who reached stable low disease activity but who withdrew adalimumab at the end of the 26 weeks had radiographic progression when they were off of adalimumab therapy. So the conclusions of the Optima study, in spite of my being able to not read a graph that I showed, are that in early rheumatoid arthritis, a short course of induction therapy with TNF inhibitor plus methotrexate might be sufficient to allow maintenance of low disease activity or remission upon continuation of methotrexate alone. But withdrawal of the TNF inhibitor results in progression of structural damage. The third study, the PRIZE study, which was initially mentioned by Artie, this is a study that was published. Paul Emery was the first author, published in the New England Journal of Medicine, had 3 phases, and the purpose of the phase 1 was to evaluate the efficacy and safety of etanercept plus methotrexate treatment of methotrexate in biologic-naive patients with active early rheumatoid arthritis. Phase 2 was a double-blind phase to assess whether efficacy could be maintained by reducing the etanercept dose from 50 milligrams to 25 milligrams and continuing the methotrexate, or withdrawing the etanercept, continuing methotrexate, or withdrawing both. And then finally in phase 3, all drugs were withdrawn, and it was assessed whether withdrawal of therapy would allow continued control of disease. This study enrolled 306 patients with active early rheumatoid arthritis, moderate or high disease activity, DAS28 of greater than 3.2, disease of less than 12 months duration, methotrexate and biologic naive. Other DMARDs were allowed with washout, and patients had to be on stable glucocorticoids. This is the study schema. Phase 1 is the open label trial. All patients were treated with etanercept 50 milligrams subcutaneously weekly and oral methotrexate at doses between 10 and 25 milligrams weekly, and they were treated for 1 year. Then those patients who were in DAS28 remission at 1 year were randomized to this double-blind phase where they were treated either with etanercept 25 milligrams weekly and oral methotrexate, placebo injections and oral methotrexate, or placebo injections and an oral placebo. And this double-blind phase lasted 39 weeks. The patients then who were still in DAS remission at weeks 24 and 39 of the double-blind phase had all treatment withdrawn and were followed till week 65. The primary endpoint were the proportion of patients with sustained remission, which was defined as DAS28 remission at weeks 24 and 39 with no glucocorticoid therapy between weeks 0 and 12. There are a number of secondary endpoints that were examined, and here I'll try to read this graph without making mistakes. The double-blind phase, so the 0 time point is after all patients had been treated with 1 year of etanercept 50 milligrams weekly plus methotrexate. And the top line are the patients who were on reduced dose etanercept 25 milligrams weekly and methotrexate. The dotted line are patients who withdrew etanercept and were on methotrexate alone, and the gray line is the patient group who were treated with placebo. And you can see here that fewer patients remained in DAS remission with methotrexate alone, and even fewer with placebo alone than with reduced dose etanercept. However, there was a slight drop-off with reduction of the etanercept dose. When all drug therapy was withdrawn at week 39, there was a further drop-off in all groups. In terms of radiographic progression, during the double-blind phase, this is 1 year of treatment. Everyone was getting etanercept plus methotrexate, and then the double-blind phase with reduced treatment, there was no radiographic progression among patients who reduced or stopped treatment. So the conclusions of the PRIZE study were that in patients with early rheumatoid arthritis who achieved DAS28 remission on full dose etanercept and methotrexate, reduced dose etanercept plus methotrexate resulted in modest loss of efficacy. Withdrawal of etanercept or withdrawal of methotrexate resulted in steep declines in the outcomes, but there was no significant difference in radiographic progression. So the overall conclusion of the study is that one cannot withdraw etanercept or methotrexate even in early rheumatoid arthritis and maintain the clinical response. The fourth study that looks at patients with early rheumatoid arthritis is the Avert trial, which was shown by Artie and Jack. The purpose of this study was to evaluate safety and efficacy of subcutaneous abatacept, either alone or in combination with methotrexate compared to methotrexate alone in methotrexate-naive patients with early rheumatoid arthritis. This is a similar study designed to that of the TEMPO trial, which was Lars Klareskog's publication looking at etanercept alone or in combination with methotrexate compared to methotrexate alone in methotrexate-naive patients. This study looked at induction of clinical remission at 12 months and then sustaining drug-free remission at 18 months. 351 patients with active early rheumatoid arthritis with symptoms of up to 2 years who were anti-CCP positive and methotrexate naive were enrolled if they had active synovitis of at least 2 joints for at least 8 weeks. Patients were required to be in moderate or high disease activity and be on stable glucocorticoids. The study design is shown here. 351 methotrexate naive patients were randomized to the 3 different groups, and then therapy was withdrawn at 12 months, and there was open label rescue for flaring with abatacept 125 milligrams subcutaneously weekly and methotrexate. There were co-primary endpoints, which were the proportion of patients achieving DAS28-CRP remission for abatacept plus methotrexate compared to methotrexate alone at 12 months, and then at both 12 and 18 months. And here you see the baseline characteristics. Even though patients were allowed to have up to 2 years of disease, the mean disease duration was about 6 months. Patients had high disease activity, a HAQ-DI in the mid-range at 1.4, and 95% of the patients were rheumatoid factor positive. All were required to be anti-CCP antibody positive. So what did they find? This was a graph that Artie showed, and what you can see here is that patients were treated with abatacept plus methotrexate, abatacept monotherapy, or methotrexate alone. There was a greater proportion of patients achieving DAS28 remission with the combination compared to monotherapy with abatacept, and methotrexate alone was fairly similar to abatacept monotherapy. But when treatment was withdrawn, when abatacept was withdrawn, all therapy was withdrawn, you can see that there were steep declines in all 3 groups, and 18.5% of patients remained in remission at months 12 and 18 with the combination compared to 12% and 9.5% with either monotherapy. So the conclusions of the Avert study are that remission can be maintained after rapid withdrawal of all therapy in early rheumatoid arthritis patients receiving abatacept plus methotrexate. Patients treated with abatacept and methotrexate achieved significantly higher rates of DAS28 remission than those treated with methotrexate alone, and a small but significantly higher number of patients treated initially with abatacept plus methotrexate achieved a sustained drug-free DAS28 remission following withdrawal of all rheumatoid arthritis treatment. But as has been pointed out by previous speakers, DAS28 remission is not as stringent as SDI remission or CDI remission, because you can have up to 9 swollen joints if you have no tender joints and a SED rate of 1 and still be in DAS28 remission. Similarly, you can have 9 tender joints with no swollen joints and a SED rate of 1 and still be in DAS remission. So in early rheumatoid arthritis, drug-free remission may be possible with abatacept. So the summary for early rheumatoid arthritis is that very early treatment of rheumatoid arthritis may control disease activity regardless of whether or not biologic therapy is initiated. Sustained drug-free remission can be achieved in some early rheumatoid arthritis patients who undergo induction with methotrexate plus a TNF inhibitor or methotrexate plus abatacept. But withdrawal of the biologic agent usually results in loss of efficacy and progression of structural damage. I'd like to turn now to established rheumatoid arthritis and then conclude with inflammatory bowel disease. There are 3 clinical trials in established rheumatoid arthritis that I'd like to review: PRESERVE, CERTAIN, and HONOR. PRESERVE is etanercept dose reduction or withdrawal in rheumatoid arthritis patients achieving low disease activity on full dose etanercept plus methotrexate. CERTAIN is induction of remission with certolizumab pegol, followed by withdrawal of certolizumab pegol in patients with sustained remission. And then finally, HONOR is an open label study discontinuing adalimumab after achieving remission with the combination of adalimumab and methotrexate in Japanese patients. PRESERVE is the prospective randomized etanercept study to evaluate reduced dose etanercept plus methotrexate compared to methotrexate alone for effectiveness and radiographic endpoints in a population of patients with moderate disease activity of rheumatoid arthritis. And 834 patients with moderately active disease, a DAS28 of between 3.2 and 5.2, despite methotrexate therapy, were enrolled. Mean disease duration was 6.9 years. Patients were biologic naive, and they were on a stable dose of methotrexate between 15 and 25 milligrams weekly for at least 8 weeks before screening and stable glucocorticoids. This schema shows the study design. The open label run-in period lasted 36 weeks, where these patients were treated with etanercept 50 milligrams weekly plus methotrexate, and then those patients achieving sustained low disease activity, which was defined as a mean DAS28 of less than or equal to 3.2 between weeks 12 and 36, and DAS28 less than or equal to 3.2 at week 36, were randomized to either continue full dose etanercept plus methotrexate, reduce the dose of etanercept to 25 milligrams weekly and continue methotrexate, or go on placebo injections with continued methotrexate. The primary endpoint was the proportion of patients in either the full dose etanercept group with methotrexate or the placebo plus methotrexate group who maintained low disease activity at week 88. The conditional primary endpoint was the reduced dose etanercept group maintaining low disease activity at week 88, and there were a number of secondary endpoints which are just listed on this slide for completeness sake. Looking at the proportion of patients maintaining low disease activity at week 88, the primary endpoint and the conditional primary endpoint, you can see that significantly more patients treated with etanercept, either full dose or half dose, achieved DAS28 low disease activity, DAS28 remission, the more stringent SDI remission or SDI low disease activity than did patients treated with placebo plus methotrexate, shown in green. Here you can see during the first 36 weeks, the patients were treated open label with full dose etanercept, and patients lowered their mean DAS28 down to a range of remission. Patients achieved, about 80% of patients achieved DAS28 remission, but when patients were randomized to either discontinue etanercept and remain on methotrexate, shown in green, the proportion of patients maintaining remission dropped down to around 25%, as opposed to about 60% of patients who continued either full or half-dose etanercept, maintaining DAS28 remission. Radiographic progression during the randomized period occurred in patients on methotrexate alone, but not on patients with either full or half-dose etanercept. So the conclusions of this study were that conventional or reduced dose etanercept plus methotrexate more effectively maintained low disease activity than methotrexate alone after withdrawal of etanercept, and there was less progression of structural damage in patients who continued to receive either full or half-dose etanercept with methotrexate compared to methotrexate alone. The overall conclusion was that you can lower the dose of etanercept in patients with established rheumatoid arthritis, but you can't withdraw etanercept and maintain the clinical response. The next study looked at certolizumab pegol induction and then withdrawal of therapy in patients with low disease activity. And this study enrolled 194 patients with moderately active rheumatoid arthritis despite methotrexate, duration of disease between 6 months and 10 years. And patients had to have at least a CDAI of 6 and less than or equal to 16, moderate disease activity, 2 swollen or tender joints or more, and then the acute phase reactant criterion that's typical of trials. Mono or combination DMARD therapy was allowed with methotrexate, leflunomide, sulfasalazine, and/or hydroxychloroquine for at least 6 months prior to baseline, with a stable dose for at least 2 months and stable glucocorticoids. The study schema is shown here. Patients were randomized to either induction with certolizumab pegol and maintenance with 200 milligrams every other week plus DMARDs or placebo, and then at week 24, patients in CDAI remission stopped certolizumab pegol or placebo and remained on DMARDs alone. Patients had moderately active disease, and what you can see here is that patients completing 52 weeks of treatment after withdrawal of certolizumab pegol maintained remission in 3 of the 17 prior certolizumab pegol treated patients and 2 of the 6 prior placebo treated patients, and several more of the certolizumab pegol treated patients remained in low disease activity. The time to loss of remission is shown on the right, and the median duration of remission, CDAI remission, was 42.5 days after withdrawal of therapy. So in rheumatoid arthritis patients with established disease, one has difficulty achieving stringent CDI or SDI remission, and one cannot withdraw certolizumab pegol and maintain the clinical response in most patients. Finally, the HONOR study was an open-label, non-randomized trial in Japan to look at the possibility of discontinuing adalimumab for 1 year without flaring. And the study enrolled 197 Japanese patients with active, moderate to severe rheumatoid arthritis receiving every other week adalimumab and methotrexate. What is important to note here is that the methotrexate dose ranged between 4 and 16 milligrams a week, which is the allowed methotrexate dose in Japan at that time. The study schema is shown here. 197 patients were treated, and then at time 0, the adalimumab was discontinued, and they were followed for 1 year, looking to see the proportion of patients with sustained remission after stopping adalimumab. The baseline characteristics are shown here: DAS28 of high disease activity and HAC around 1. The disease activity at 1 year after adalimumab discontinuation is shown here, and significantly more patients who continued adalimumab were in DAS28 remission, low disease activity, or SDI, low disease activity or remission, than patients who had stopped adalimumab. So 79% of the patients who stopped adalimumab were able to continue remission without flaring if their DAS28 was less than 2 at the time of discontinuation of adalimumab, and they maintained functional remission and structural remission in 94 and 100% of patients. So the summary of this study and the other studies in established rheumatoid arthritis are that achievement of stringent remission is difficult. Withdrawal of biologic agent usually results in loss of efficacy and progression of structural damage. One can lower the TNF inhibitor dose in patients with low disease activity, but cannot withdraw the TNF inhibitor and maintain clinical response. And patients with deep remission, a DAS28 of less than 2, may be able to withdraw the TNF inhibitor without flare. I'd like to conclude with 2 slides about inflammatory bowel disease. This was a prospective study at 9 GI units in Finland to look for the relapse rate after stopping maintenance therapy with TNF inhibitors in patients with inflammatory bowel disease who were considered to be in deep remission. There were 52 patients with Crohn's disease, ulcerative colitis, or unclassified, and they had to have no clinical symptoms, endoscopic remission, and normal fecal calprotectin concentration as the definition of deep remission. Patients underwent repeat endoscopy at 4 and 12 months after stopping the TNF inhibitor, and at a median of 12 months after stopping the TNF inhibitor, 2/3 of the patients remained in clinical remission. Of these patients who remained in clinical remission, 85% were also in endoscopic remission, and relapses occurred at a median of 6 months after stopping the TNF inhibitor in 29% of Crohn's disease patients and 35% of ulcerative colitis patients, but these patients responded to reinitiation of TNF inhibitor therapy. So the overall conclusions are that sustained drug-free remission is possible in some patients with early rheumatoid arthritis who undergo induction with methotrexate plus TNF inhibitor or methotrexate and abatacept. One cannot usually withdraw the TNF inhibitor and maintain clinical response in patients with established rheumatoid arthritis, but if deep remission has been achieved, one may be able to withdraw the TNF inhibitor and maintain the clinical response in patients with established rheumatoid arthritis or with inflammatory bowel disease. So with that, thank you very much for your attention.